Okay, we're going to go ahead and get started. Welcome to the quarterly meeting of the Sacramento County Opioid Coalition. My name is Janet Dumonchel. I am co-chair of the executive committee, along with Lindsay Coate. She's the other co-chair. And the Sacramento County Opioid Coalition is a collaboration of healthcare professionals, community-based organizations, law enforcement, county agencies, and concerned citizens determined to turn the tide of our local opioid epidemic. And so we are, happy to be here today to present updates on what's happening in our community. And also we have a really wonderful slate of speakers that are going to be covering different topics. So with that, if we could have Lauren, if you could please give the community updates.
Yes, of course. Thank you, Janet. Thank you everyone for joining me today. I'm going to share my slides here really quick. Okay. Is that coming through okay for everyone?
Yes.
Great, thank you. So I just wanted to provide some updates on our Gone Too Soon Memorial Project. We were able to kind of have our display in its full glory at the Sacramento County Prevention Summit at the end of March, and just to kind of show the 17 families we currently have participating. And just want to put it out there that this community impact has been able to reach over 24,000 members of our community since October of last year. And so we've been able to travel around to a lot of different high schools, a lot of different events. And with that, since I am at a lot of events, I want to share with the community that feel free to invite our memorial project, to your memorial event, your safety event, your fundraiser event. It's been really nice to just have this exposure and share. We are always taking applications as well. So if you know any families who want to participate and honor their loved ones in this way and share education throughout the community, I will put a link in the chat to the application page on our website. And then next, we are still looking for an AmeriCorps Vista. So this is a wonderful job opportunity that we have that you'll be working alongside me at the Sacramento County Opioid Coalition under the Sierra Sacramento Valley Medical Society. And so if you know anyone who is looking to really network and just work on distributing naloxone in the community, working with youth, working with events, increasing awareness, and a lot of the anti-stigma media campaigns that we do, if you know anyone that is interested in getting this sort of experience, I will also put the link to this in our chat. And we would love to just grow our team in this way. I really love working here, and I think like minds will recognize each other and hopefully join us soon. So there's that. And then again, just another reminder that I am continuing to do Narcan training and harm reduction throughout the community. I have an hour-long presentation where I focus on what harm reduction looks like in this age of fentanyl. And every time I give this presentation, I provide Narcan kits, and whether I'm in person or over Zoom, I'm able to get those kits to you. We provide shipping, or I transport myself and my computer and all the supplies that I need just to kind of have that one-on-one interaction, whether that's with school groups, companies who want to train their staff, and anyone that's really interested. Really, I'll do groups of 100, I'll do groups of 4. It really just depends on who wants that information for their people. And then here's our big reveal. We have our first Here to Heal meeting happening this Sunday, the 23rd, and it's going to be on Fulton Avenue, Hurley Way. That's near Fulton, but it's in Hurley Way on a Sunday at noon. And basically, we're finally opening up a safe space for people to connect, and it's open to anyone who has lost a loved one to opioids. We're focusing on those who have lost a loved one first, and then eventually we might open up a new group for those who are still currently struggling with someone or has a loved one who is struggling with opioids, just because we recognize that those are two very different experiences, and those two different groups of people really need different types of support. but I've been to a few memorials and healing spaces throughout Sacramento, and it's really hard to do these sorts of things in like public parks or places where people aren't feeling safe. There's none of that noise cancellation, and so I really just felt like there was a huge need for this. And so if you know any families or know any friends or loved ones that kind of are feeling a little bit lost and just want to connect, we aim to learn without any expectations or any pressures, right? So everyone's healing journey is completely unique, and we just really want to highlight a safe space for people to connect. So this will be our first one. There'll be like a brainstorming and housewarming session. We'll have snacks and things like that just to get us started. And we really want this to be led by the community. And so we're not going to tell anyone, this is what we're doing. It's going to kind of be, what does the community feel like they want to learn? So please share. I'll send up a follow-up email with this invitation as well. I'd love to see some people connecting. And that is it. I'll send everything in the chat. Thank you very much.
Okay, thank you, Lauren. Okay, and so now I'd like to introduce our first speaker, who's going to give an update on fentanyl cases. Phil Talbert, he's the United States Attorney for the Eastern District of California. He leads a 90+ attorney office with locations in Sacramento, Fresno, and Bakersfield, serving over 8 million people. Mr. Talbert's career has included over 20 years of service in the Justice Department, where he has held a number of leadership roles, including serving 2 stints as acting United States Attorney under 2 separate presidential administrations. On April 22nd, 2022, President Biden nominated him as U.S. Attorney, and the Senate confirmed him on June 23rd. So please welcome Phil Talbert, speaking on an update on fentanyl cases.
Thank you, Janet, for that warm introduction. I'm really happy to be here and happy to be able to update the group on kind of what's the work of our office in this area on the enforcement side. And just as kind of a couple general points, our office, working with our federal partners and local law enforcement partners, primarily target for enforcement the people ultimately responsible for bringing large amounts of controlled substances, including fentanyl, into our district and either distributing here or using our district as a transshipment point to send it elsewhere in the United States. We do that in part through what's called an OCDF strike force. OCDF is a program within the Department of Justice that works on essentially organized crime that is focused on drug enforcement. And our strike force is a multi-agency effort where attorneys from my office and agents from FBI, DEA, HSI, and a number of other law enforcement agencies all sit together in one place and conduct essentially joint multi-agency investigations that move up the chain as far as possible to the sources of supply for large portions of drugs that are trafficked here. So we're doing that. We're still our strike force is still relatively new, so we're still developing cases. And I think, as you'll see in the coming few years, we'll have more and more cases against larger targets, including some that have to be extradited here from other countries to face federal prosecution in U.S. courts. That's our major focus on the drug enforcement side. At the same time, we recognize fentanyl in particular has been a unique challenge for federal law enforcement and local law enforcement. And so with the DAs, the district attorneys across our district, and again, our district covers 34 counties, so we work in cooperation with 34 different district attorneys' offices up and down the valley and the Sierra Mountains. We also focus on looking at overdose deaths from fentanyl, and to the extent at the federal level, if there's a case where a dealer knew that something contained fentanyl and was had a potential for causing death, and dealt it anyway to someone, and they in fact overdosed and either died or had serious bodily injury, then that may be the type of case that we would take federally. The DAs are also prosecuting similar cases, so we usually work in cooperation in deciding which forum is the best one for that type of case. So that's a little bit out of the ordinary for us because, again, our main focus in the drug enforcement area is on the kind of going up as far as we can on the supply chain. In any of these cases, because controlled substances like methamphetamine and heroin are inherently dangerous, and then fentanyl is even more dangerous. And so we're even more careful in conducting investigations where we know that drugs are being trafficked and distributed. We have to make continual risk assessments during our investigations to make sure that we're not running an investigation so long that there are risks of someone being hurt in the meantime. So we're always careful in thinking about that based on the information that we have during an investigation, do we need to take something down quickly and either make an arrest or maybe give information to a local law enforcement agency to disrupt what's going on to prevent some harm from coming to someone, because again, these controlled substances and in particular fentanyl are so dangerous. So we do that kind of ongoing risk assessment in our investigations. Now, as I mentioned, we're focused on these larger drug trafficking organizations. When fentanyl showed up a few years ago as being a significant problem in our area, the drug trafficking organizations really already had substantial distribution networks in place. And what we're seeing in our cases is that these drug trafficking networks are selling fentanyl as just another product in their product lineup. So often an investigation that focuses on a methamphetamine trafficker will also involve heroin, will also involve cocaine, will also involve fentanyl. And over time, we've seen increasing amounts of seizures, so that what was once, if we found fentanyl, maybe a gram or 2 grams or something like that, now we're finding tens of pounds, or kilograms of fentanyl, along with large amounts of those other drugs too. There's been a new product strategy used by the drug trafficking organizations, from what we've seen, that the problem that we have is not all supply driven, but it's also not all demand driven. So in some ways, if there's a new product, if it's first we saw powder, then we saw the counterfeit M30 pills, and other types of counterfeit pills. Then we saw the rainbow pills and the colored chalk. We're seeing fentanyl cut with other types of agents that are also dangerous in their own way. And then we're also seeing heroin and cocaine cut with fentanyl. So over time, we're seeing more and more new things tried out in the marketplace. Some of those new things are creating their own demand, which then reinforces the supply that's coming. So it's kind of this vicious cycle that we're facing, where it's not just a demand problem, it's not just a supply problem. And I've often said, when I've spoken about fentanyl in particular, other drugs too, that we're never going to prosecute our way out of these problems, but we need to take this multi-pronged approach where we're working on prevention, we're working on disruption, we're also working on enforcement at the same time. One other thing I want to call out, and I'm going to give you a few example cases as far as things that we have currently charged, or that we had charged and have gone through the court system. But one thing that I've seen that is say different than when I was a line prosecutor in this office about 15 to 20 years ago, prosecuting mainly methamphetamine trafficking cases. There are a lot more guns involved. When I was prosecuting cases, I thought of many of the defendants that I was prosecuting mainly as business people. that they were out to make a buck, and they really weren't looking to create any violence, or, if they had a gun, usually was defensive purposes. Now, most of our cases involve guns. And the guns that they involve are not just the pistols and rifles and shotguns from the time that I was prosecuting cases, but we have more semi-automatic and automatic firing guns. We have what are called switches. And for those of you new to kind of firearms area, a switch is a little piece of metal that can be placed inside the gun to convert it into an automatic firing weapon, which is essentially a machine gun and illegal in the United States without registration, and no one has registration for this. Ghost guns, which are privately made firearms bearing no serial numbers, so they're very hard to trace. Some drug traffickers are also selling guns or switches along with their product lineup of the drugs that they're selling. So all these things are relatively, I would say relatively new, definitely new over the past, few years or so in our area. The other thing is the way that people are communicating with each other. When I was prosecuting cases, of course, it was mainly over cell phone, voice calls, and so of course we had the potential for wiretaps and tape calls from if we had a cooperator or a confidential source. Now a lot of sales are arranged over social media, and so the communications can be over social media. Some of those are encrypted in ways that we can't get into, and so harder for us to investigate some of the cases that we're looking at. Also, social media, of course, is much more accessible to younger customers, and so as we see younger and younger people are getting involved in ordering up fentanyl and that sort of thing over social media. One thing I wanted to share with you, and this is still relatively new and I guess incomplete, is in Fresno, we're getting some encouraging news on the fentanyl front. Starting in 2019, various Fresno law enforcement and public health authorities engaged in a coordinated multi-pronged awareness and enforcement campaign. For us, this really started in early 2019 with the Darnell Pearson case, where there was one person, Darnell Pearson, who was responsible for 4 overdoses in the Fresno area, 2 of them resulting in deaths on the same night. We prosecuted Mr. Pearson. He was ultimately convicted at trial and sentenced to 30 years in federal prison. Later in 2019, we followed that case up with a summit for educators, raising awareness about opioids and the dangers of fentanyl, and that. Then there's been kind of additional awareness campaign efforts. A local TV station did a documentary on a couple of our investigations and cases that got aired. Now it's apparently available nationally on Hulu and some other sources. The district attorney and a task force agent from DEA engaged in a number of kind of school awareness campaigns, going to schools and holding kind of all high school assemblies where students would listen and hear about the dangers of fentanyl. At the same time, they were providing flyers, sending flyers home to parents with information about the dangers of fentanyl. And then we also were very intentional to hold press conferences whenever we could about fentanyl prosecutions we were doing. And at one point, following the overdose death of a high school student at Clovis North High School, we did a press conference where a public health doctor got on screen and said that, and this was in June of 2021, said fentanyl, not COVID, is the biggest killer in the Central Valley, which was literally true. So a number of different actions. And on the enforcement side, we had DEA, HSI, Fresno PD, and some other law enforcement agencies join up together with public health authorities and form what they've termed as FORT. And I think if I have it right, it's Fentanyl Overdose Resolution Team, which is anytime there's an overdose in Fresno County, this team would go out and try to gather as much information as they could. And the emphasis was not on prosecuting people either who used fentanyl or who may have one friend who hands a pill to another friend, that sort of thing, but to offer services and treat them like victims, and try to get as much information as they could from those people. Where did the fentanyl come from ultimately? And then where we could, bring cases against what seemed like either the federal or state level against the people who were dealing the fentanyl out that was causing overdoses. So all of those efforts together from 2019 until today, the statistics on overdose deaths in Fresno, we saw, just like we've seen other places in the country, substantial increases from 2018 through 2021. And then the numbers for 2022 were lower than for 2021. And then in the first 2 months of 2023, the numbers are even much lower than they were in 2022. So I haven't found many jurisdictions in the country, in talking to my fellow U.S. attorneys around the country, that have experienced actually a decrease. Now, I'm knocking on wood as I say that. It is very early on. It is preliminary. We could still see a blip upward, but taking this kind of multi-pronged approach, using agencies across and both enforcement and prevention awareness areas, that we are seeing some better numbers. And I'm thinking about how that might translate to whether it's here in Sacramento or other places across my my district here. Okay, so that's kind of my basic introduction. And I wanted to follow up with a few actual, like, this is what a federal case involving fentanyl looks like today here in our district. I'll give you a few examples, and then I'll kind of watch my time and make sure that I don't go over and stop when I've run out. So let's see, we had two gentlemen, Gilbert Ramirez and Michael Lovato of Sacramento. Oh, and I'm sorry, I should say these cases that I'm drawing on, because I wanted to tell you about all current cases. So I'm drawing from across the district. So there will be some Sacramento, but there's some up and down the Central Valley. And some of them are concluded. Other ones we've just recently charged. So some of them are still in progress in the courts. And I'm just keeping to public information on these cases. So in any event, Gilbert Ramirez and Michael Lovato of Sacramento sold over, and all of these are allegations, of course, from the government, sold over 11,000 fentanyl pills and 2 pounds of methamphetamine to a confidential informant. We indicted the two of them in January of this year, 2023, for conspiracy to distribute and possess with intent to distribute both fentanyl and methamphetamine, and also distribution and possession charges. Eric Pena of Modesto advertised counterfeit fentanyl pills and also switches. And if you remember, the switches refers to the little piece of metal that you can put into a gun to render it an automatic firing weapon. We had undercover agents arranged to purchase switches from Mr. Pena. And then in a search of his car, officers recovered pistols, 26 switches, and they were specifically Glock switches. So Glock is a firearm manufacturer, a legitimate firearm manufacturer out of Austria. And Glocks happen to be one of the weapons of choice for drug traffickers. And so a lot of switches are made specifically for Glock weapons. They're not made by Glock, but they're made for Glock weapons, so they can render a Glock pistol into a automatic fire weapon. So pistols, 26 Glock switches, fentanyl pills, and heroin, all in his car. And then a search warrant on his residence found more firearms and switches, high capacity magazines, and controlled substances. He pled guilty in October 2022 to possession with intent to distribute fentanyl, and also using or carrying a firearm in relation to drug trafficking crime. His sentencing is scheduled for June 2023. So typically in the federal system, someone who pleads guilty is not sentenced immediately, but a pre-sentence report is prepared after an investigation by the probation office, and so sentencing is put out away. So his sentencing is coming up in 2023. Another case out of Sacramento, Jairo Leonidas Qua. In 2022, Mr. Leonidas Qua sold an undercover powder fentanyl and counterfeit M30 pills. M30 refers to the oxycodone. That the counterfeit ones contain fentanyl. A search of his residence found over 20,000 counterfeit M30 pills and over 1 kilogram of fentanyl-laced heroin. So again, we see another drug like heroin, and it's now laced with fentanyl. He was charged, convicted, and he was sentenced to 4 years, 3 months in prison. And we're also prosecuting his supplier, Carlos Calel, who pleaded guilty last October, and he's scheduled to be sentenced in May of this year. Let's see, let me give you, one or two more. Alfonso Jimenez of Stockton. In 2021, 2022, some confidential sources purchased pounds of controlled substances from him and a co-conspirator. In February of 2022, he delivered 28 pounds of methamphetamine to the co-conspirator for further distribution. And on that basis, law enforcement did a search of his residence and recovered over 31 kilograms of meth, over 28 kilograms of cocaine, over 6 kilograms of heroin, and over 350 grams of counterfeit M30s containing fentanyl. Almost $300,000 cash and a firearm. We charged him. He pleaded guilty in February of 2023 and is scheduled for sentencing in May of this year. And I think with that, I've probably run out of time, and I've given you some good examples that show some of the points that I made earlier. So anyway, thank you so much for the time to give you an update from our office on what we're doing in this space. Thank you, Janet.
Oh, no, thank you so much. It's really encouraging to hear how, education is actually contributing to, reducing some, fentanyl use, and also the efforts, of your, your organization in actually prosecuting these, drug dealers and illegal gun traffickers. So, we applaud your efforts and, support the ongoing efforts, this to try to get a handle on this epidemic. So thank you very much. Are there any questions, quick questions we have?
I do have a quick question, just out of curiosity. I know last time I checked, it looked like Xylazine wasn't currently a controlled substance. And I was wondering if you've detected anything or seen any Xylazine mixed in fentanyl heroin in any of your reports?
I've heard from the agents that's currently happening. Yes, I think it started more on the East Coast, but we've been seeing it. I think we first started seeing it here on the West Coast in the Bay Area in San Francisco. Okay. But we're seeing it here too.
Okay, thank you.
Mm-hmm.
And it looks like Sherry.
Yeah, I just wondered, do you know the name of that Hulu documentary that you mentioned earlier?
Oh, I think it's called Killer High.
Okay.
I can hold on.
Okay.
Hold on, if you let me look at one other document, I think I may have it right here.
Okay.
And I think it's available on some other platforms too.
Okay.
Let's see, it was done by ABC 30. Let's see, it's called Killer High, The Silent Crisis.
Thank you.
And it says, Roku, Amazon Fire TV, Apple TV.
Great.
And Android TV. So I guess, sorry, it's not on Hulu.
That's okay. I would have found it. Thank you.
Yeah, you bet.
All right, well, thank you again. And now we'll, move on to our next presentation. So we have a presentation from Sacramento County on Xylazine, giving a Xylazine overview and ODMAP update. And we have two speakers, Michelle Allen Bessie. She is an LMFT, Clinical Health Program Manager for Sacramento County. And she has been in the field of substance use and mental health for over 20 years. Her passion is sharing and collaborating with different agencies and departments to increase positive outcomes for high-risk clients. And presenting with her is Felix Tran, who also works at the Sacramento County Department of Health Services as an epidemiologist. So please welcome Michelle and Felix.
Thank you so much. Welcome. So I have a presentation on xylazine right here. And if I can share my screen. There we go. Can everybody see that okay? Thank you so much. So xylazine, as you heard, it started on the East Coast, but it is definitely here in Sacramento. So xylazine is a horse tranquilizer and a sedative for large animals with pain-killing and muscle relaxant properties. So we often see it mixed with heroin, cocaine, meth, and other street drugs. And it's led to increased overdose across the country. We often hear it referred to as trank dope, sleep cut, but also it's in substances and people aren't necessarily aware that it's in those substances. So what is it? It's not approved for use in humans, and it's not an opiate. It's a deep sleep sedative, and it starts quickly and makes you what people refer to sometimes as fall out hard for about the first hour. Xylazine extends the high and can be referred to as giving fentanyl legs. So it's very potent and dangerous. There's not a lot known about the long-term health effects of chronic exposure to xylazine, and it's not made for use in humans. So recently, there's been a lot of news on xylazine, and xylazine being a huge concern in the United States, being the newest threat, xylazine and fentanyl. Xylazine is making the deadliest drug threat in our country, fentanyl even deadlier. And there's recently been alerts from the FDA and the DEA. So looking at our local data, xylazine has become prevalent in the drug supply. We don't know the full impact of xylazine on our communities, but what we do know is that our crime lab has seen it in 10 deaths here in Sacramento County, and it has been mixed with fentanyl. In those 10 deaths, we saw it 4 times as solids, 3 times as powders, and 3 times as tablets. So xylazine can be swallowed, inhaled, smoked, snorted, or injected into the muscle or the vein. It only takes 1 to 2 minutes for people to start to feel the effects, and it peaks in about 30 minutes. The effect lasts up to 4 hours and can improve the euphoria and prolong the duration of the fentanyl. And it really extends the high and gives it a stronger effect. So fentanyl and xylazine mixed together, it gives that better high, but it also increases the risk of overdose and of death. So some of the health effects that we've seen from xylazine include skin lesions and sores. And they're very extreme skin lesions and sores that we're seeing, respiratory depression, a huge drop in blood pressure, blurred vision, disorientation, inability to respond, unconsciousness, sedation, coma, and death. So it causes the central nervous system to be depressed and includes respiratory depression, which is one of the reasons why it is so much easier to overdose. Acute toxicity from xylazine appears similar to an opioid overdose. The symptoms are present for hours, cause low blood pressure, slowed breathing, and a slowed heart rate. If in combination with other sedating drugs, it just really increases the effect of the central nervous system depression and the increase of overdose. So I have some information on the sores caused by xylazine. They can be at the injection site, and sometimes other places they're seeing. And again, there's a lot of questions about xylazine and its use, but these photos are kind of graphic. So I just want to warn everybody before we share. So these are some of the lesions that we see where people are using xylazine. So very severe necrotic wounds. They can be extensive in size and very difficult to heal on their own. There's also quite a lot of information out there on the internet about dermatologists and people in that specialty having concerns because they're seeing these severe wounds from xylazine. So again, signs of overdose, abnormal breathing, can't be woken up, skin changes, unresponsive, shallow or not breathing, snoring, pale skin, blue or purplish lips or nails, and the pinpoint pupils. If someone overdoses with xylazine, Narcan does not impact it. So the use of Narcan will not reverse an overdose for xylazine because it is not an opioid. So individuals, if they are overdosing, of course, always use Narcan, but again, it won't reverse the effects of xylazine. So some harm reduction strategies. When you see people who are sedated or unconscious longer than usual, and just be aware of that. Make sure to check that people are still breathing and their heart rate is good. Put people in the recovery position, avoid atypical positions, roll people from one side to the other, place padding under bony areas to reduce any kind of issues with not having good circulation. Again, always call 911 and administer Narcan as well. So looking at our community's needs, expanding community-based drug checking services, creating a xylazine overdose reversal drug. In the healthcare system, improving compassion between care providers and patients, making it a safe and respectful place where people feel like they can ask for support and help without being judged for their substance use disorder. Community syringe service programs, increasing access to wound care and antibiotics for infection, developing wound care guidance specific to xylazine related wounds. Again, these are things that we're just learning about as a community because xylazine is so new. And really learning and focusing on what they've done on the East Coast because it did hit there first. There are also xylazine test strips that are in the works to be developed and approved. And more research is really needed to understand and treat the side effects of xylazine. So just some information sources. There's a great fact sheet on that. The California Department of Public Health has made some great alerts on xylazine. There's an FDA warning out on xylazine in humans. The DEA has issued public health safety alert. NIDA also has some great information out on xylazine and the Center for Disease Controls, along with the DEA. Thank you so much.
Hey, do we have any questions for Michelle? Okay, I don't see anything in the chat.
Okay, and I do have something that I would like to share with you guys that is hot off the presses that came out yesterday. We have a new initiative called Safer Sacramento, and we have a video up there on xylazine. If I can go ahead and share that with you guys. And we have, this is Crystal, our crime lab here in Sacramento.
Xylazine is something we're just starting to see. The East Coast labs have seen it more than we have. Last year we had about 10 cases. So xylazine is a horse tranquilizer, and they're now mixing it in with the fentanyl. And it's something that they're not differentiating, like they're not going to go out and buy, blue pill and know that that has just fentanyl, and they go, buy the pink powder and we know that that has xylazine and fentanyl. It's a mix, so we don't know until we get the pill or that powder and we test it. So what is so dangerous about the xylazine that we're seeing is if someone is having a fentanyl overdose and they're given Narcan, the Narcan will help with the fentanyl, but it does nothing for the xylazine. So they still have that reaction or that depression from that drug.
Okay, thank you, Michelle. And I'd like to remind everyone this is being recorded, and so if you'd like to see the slides with a copy of this video, it will be on the Sac County Opioid Coalition website under meetings.
Thank you so much. We also have a lot more information that you guys can access directly on our new website, Safer Sacramento, which includes this video on xylazine, a lot of information on fentanyl awareness, a ton of great resources, and just some really wonderful things that we'd like to share with you guys. So please feel free to check that out, and I will drop the information in the chat. We also have a xylazine flyer that we have developed that I will drop in the chat as well. Then I will hand it over to Felix to talk a little bit about our ODMAP.
Thank you, Michelle. So just wanted to give a couple of quick points about some summary statistics we've seen through ODMAP. Ever since from July until February, so that's 8 months, we've had about 1,860 reported overdoses by community agencies that report overdoses to ODMAP. For roughly half of them, naloxone was administered to the patient at the scene. Among these reported overdoses, unfortunately, there were 8 that resulted in death, and the majority of those deaths, naloxone was administered. And because of the way that ODMAP requires certain information or makes certain information optional, there's very little reported information about the specific substance that is suspected in the overdose. In fact, the only agency currently in our community or that uses ODMAP that reports the suspected substance in the overdose is the Folsom Police Department. And among the ones that Folsom Police Department has responded to, the majority of the suspected drugs are either prescription opioids or heroin, or in some cases fentanyl as well. And if we look at the number of overdoses occurring by month, the number of reported overdoses peaked in August and December over the past 8 months. In February, the number seems to have dropped down to its lowest level over the past 8 months. Hopefully the trend continued in March, and hopefully it'll continue on in this month and beyond. And yeah, does anyone have any questions for me? Right. If not, thank you for your time, and feel free to reach out to me if you have any questions about ODMAP, or if you want to learn any specific information about it. I'll put my email in the chat. Thank you.
Okay, thank you, Felix.
Okay, just a couple more updates. So I don't know if everybody has heard or seen this information, but on March 29th, the U.S. Food and Drug Administration approved Narcan nasal spray for over-the-counter non-prescription use. It's the first naloxone product approved without a prescription, so we are super excited to hear that. And of course, naloxone or Narcan is a medication that rapidly reverses the opioid overdose. So we were very excited to hear about that. And then also in the news, very exciting, on April 12th, 2023, Biden-Harris administration designated fentanyl combined with xylazine as an emerging threat to the U.S. So some great information here in the news. They're saying that xylazine's growing role in overdose deaths nationwide prompted this designation for the first time in U.S. history. So although some sad news, it's great that it's getting the necessary attention.
Okay, thank you. Okay.
Thank
All
you.
right. So I'd like to move on and introduce our next speaker, Dr. Kelly Olson, who's going to speak on novel psychoactive substances and synopsis. Dr. Kelly Olson, she is a neuroscientist and author and a keynote speaker who believes that assessing and addressing disease requires an integrative approach. Kelly's ability to illuminate the molecular misadventures that leads to disease is what makes her special, proving time and again that a splash of nerdy with a dash of passion goes a long way. Currently, she holds the position of Director of Clinical Affairs with one of the largest toxicology laboratories in the United States. Here, she focuses much of her attention on mental health, particularly with an emphasis on addiction. She has lectured all over the world and has authored and co-authored a number of publications. She received her Master of Science in Exercise Physiology from the University of North Dakota and a PhD in Pharmacology and Therapeutics from the University of Manitoba. Please welcome Dr. Kelly Olson.
Great. Thank you, Janet. Thank you, everyone. It's great to be here with you guys, sort of here with you guys, but thank you very much for allowing us some time to talk with you about some novel psychoactive substances. So what I like about the previous speakers is talking about xylazine, and that is just synonymous with illicit substance use right now. And the information that I'm going to present to you will go basically dovetailing with what they spoke about with regards to xylazine. So I will share my screen and we'll start in talking just a little bit about sort of what the objectives are when it comes to learning a little bit more about novel psychoactive substances. Now, these change a fair bit. So what I mean by that is that street chemists are very, very clever when it comes to designing something on the backs of a parent compound. We call those analogs typically in science speak, but for the most part, what they are is they're either designed off of that chemical backbone, or they're based on that chemical, but they're made a little bit differently. Either way, they become their own substance. And so we'll talk a fair bit about today with regards to benzodiazepines, also known as designer benzos, and then synthetic opioids. And I'll talk about some of the more popular of those two families, if you will, but keeping in mind that even as we speak, the chemists are working on changing these chemicals and wanting to obviously put more out there. So a lot of these really started off in pharmaceutical research. They were designed in such a way that they were either made so that they weren't as addictive, or they were made to help somebody. In the case of spice, some of you know that synthetic cannabinoids were designed in such a way that they were to help somebody that was going through chemotherapy that had issues with appetite, or HIV drugs and had issues with appetite. But they found their way onto the street, and by doing so, they also had a value assigned to them. And as such, the rest is history, as they say. So they didn't all start off in a really nefarious way. A lot of them started off quite benevolent in nature. Some were synthesized due to shortages of other illegal drugs. So it was almost like an ebb and flow, if you will. When one drug or drug class went out of vogue, whether it just wasn't, the chemicals weren't available, they just weren't something that was being demanded en masse, if you will, then other things came in and rushed in to fill its place, never to be left, without substances available. They would oftentimes replace each other when there were shortages experienced. And over 1,000 individual compounds have been identified by the United Nations and other industries, other agencies, if you will. But again, as I mentioned, that number continues to increase. And not only the number, but the type of substance as well. Most of them are still being imported from China, especially things like obviously fentanyl. Although the bulk of the fentanyl that we're seeing now is being filtered up through the cartels, and those ingredients that make fentanyl are coming from China. So things are shifting a little bit. Xylazine is no exception to that. That is something that we are seeing, these street chemists, creating, etc. So these things just kind of ebb and flow, but oftentimes they get their start as a chemical coming in from China. We also know too, that in order to get these substances, it used to be a little more challenging. Now it's a simple string of emojis, and you guys know this already, on Snapchat or TikTok, or a certain sign, if you will, in order to get these substances. So it's very, very easy. Also getting it through the mail, simple ways. You basically masquerade as being someone who's 21, click a box, provide a credit card, and a pill comes right to your door. So, and again, a lot of those synthetic opioids are in fact coming from China. Some of you may have remembered a substance called pink, not the singer, but an actual substance. But that particular substance, also known as U47700, was a synthetic opioid that really had a heyday in terms of its ability to be obtained from China. So these substances are definitely readily available. Today, what we're going to talk mostly about in this, brief introduction to these substances will be the benzodiazepines and also the opioids. So kind of the top left and then the middle on the top. We'll really focus on those and really what to expect on the street and why folks are utilizing these substances as well. When we look at this particular foundational study, if you will, this is looking at, again, the 2021 kind of a year in review. So oftentimes these agencies lack about 12 months, sometimes up to 18 months. But they were looking at novel psychoactive substances, like the detections of those in urine. And these were in samples analyzed since 2018. Again, 2018, 19, 2020, and then 2021, each of those color coded. And you can see as of 2022, these so-called designer illicit benzodiazepines were the most commonly identified NPS, or novel psychoactive substance. So again, these are substances, when we talk about designer benzos, that have no prescriptive value here in the United States. And we'll get into that a little bit more when we talk specifically about those. Now, why are folks choosing these substances? Well, this list, you all know it because you deal with that with your patients and clients. Anything when it comes to struggling with an addiction, potentially any one or maybe a combination of these reasons pops up. So things like experimenting. I remember talking to some high school girls when I was doing some substance use prevention community events. And I remember, I'm a volleyball player, and I trained with the Canadian national team. And I remember specifically talking to these young ladies about, you know, their volleyball scholarships or basketball scholarships. And I remember asking them, you know, why would you go to a party that, you know, and stay at these parties where everybody was doing these substances in the bathroom or in the kitchen or the whatever? And they said, you know what, Kelly, our friends were having fun and they weren't dying. And so we wanted to try it too. And then you fast forward a few years to today's time, and this so-called experimenting that a lot of folks were used to oftentimes comes with, you know, fairly swift death. And so we have to be mindful of the fact that, you know, gone are the days of trying substances and having fun or experimenting. However, it still remains a reason why folks utilize these substances. Now, seeking options that are more easily available, for example, like I said, a string of emojis on Snapchat's pretty easy to be able to then meet your dealer and be able to pick up your substances. Seeking options that are less expensive speaks for itself. Looking to evade detection, absolutely. And then this last one, I always find a little bit interesting, but in speaking with folks, believing that things are more safe because they're natural tends to be something that kind of bubbles up in terms of sort of reasons why things are chosen to consume. And that's not always the case, obviously. So just because they're natural does not mean they're safer. Now, let's start with the benzodiazepines. And I want to specifically start with these because these benzodiazepines, the novel or designer benzos, there has been one that has been found to be utilized in conjunction with xylazine. So it was very, very, very well said that xylazine is being utilized in conjunction with fentanyl. But we're also noticing as well in a lot of different reports that they're layering it with other substances. So it's bad enough that we have the co-use with fentanyl, but we've also seen xylazine being utilized with cocaine, certainly with gabapentin. But there's another substance as well that fits under this umbrella, if you will, of the designer benzos. And that one is called bromazolam. So again, no prescriptive value here in the United States, but it was found on the East Coast in conjunction with xylazine. So watch that as well. We definitely and justifiably so want to see it or look for it, I should say, with fentanyl, the folks that we are assisting that have an opioid use disorder. But keep in mind that we're also seeing it with other substances like these designer benzos. So these were, again, to remind you, the most commonly identified novel psychoactive substance last year. There is one, for example, it's called etizolam, and you can see that written there in parentheses on the screen. That particular substance is prescribed in Italy, India, and Japan, but again, not here in the United States. As a matter of fact, everything that I talk about in these slides, as I mentioned, none of them have prescriptive value here in the US. So one more time, these have been involved in fatal and non-fatal overdoses, but again, oftentimes in combination with other opioids or other benzodiazepines, or now things like xylazine. Certainly we see them sold online on the dark web, but we've also seen them as well just in regular web surfing too. They can be available in powder, tablet, liquid form. So pretty much everything that was described with xylazine availability, that's what we're seeing with these designer benzos as well. But The key is that oftentimes when they're pressed into these counterfeit tabs, the idea is to make them look like a prescription. Now you can see on the sort of the right-hand side of your screen, the chemical structure. Basically what this is saying is these designer benzos, they act exactly like a benzo would, a prescribed benzo here in the United States, and they attach to the same receptors in the brain that our prescribed benzodiazepines do as well. The difference there is the potency. These potencies can vary quite significantly with these designer benzos. And there's one, and you can see it at the bottom here, this flubromazolam. It has been reported to have side effects that include things like prolonged severe intoxication, and these things can oftentimes be associated with coma. So very, very significant and very, very scary substances out there. Now, immunoassay testing, just for those of you that are testing for these substances, you will notice that there's a fair bit of cross-reactivity, so you may not be able to pick up the designer benzodiazepines with a benzo strip. Those benzo strips on the point-of-care cups, for example, are most often calibrated to oxazepam, which is quite an old benzodiazepine, but at the same time, these designer benzos are different enough that you may not be able to pick them up with the cups. Now you can pick them up with definitive testing as long as the folks are testing for those specific substances. We in fact do that, but you want to look for that if you are interested in assessing these benzos. Now I've listed here just on the side, on the right-hand side, toward the bottom of the page, the current designer benzos that we test for. The reason why I like to keep church and state separate, I don't talk a lot about the business, but I want you to know about what it is that we do test for. These are the common designer benzos that we see on the street today. And so just keep that in mind. Again, there are a number of these designer benzos. I mentioned one that tends to be mixed with xylazine, not to the degree we see it with fentanyl, but it is something where we are seeing layering. Last section I just want to touch on are the novel psychoactive opioids. Again, a lot of them masquerade as prescription opioids that we have in typical circulation on the prescribed side, but in atypical circulation on the illicit side. Now, these substances are structurally different than fentanyl analogs. So if you are testing for various analogs, make sure that when I show you a list of the more common ones, you're testing specifically for those. With the fentanyl test strips, etc., it's very unlikely you'll be able to pick up these synthetic opioids. So just watch for that as well. They are most certainly sold online. As I mentioned, they can come in the mail very, very easily. They may also be sold as another substance. So punched into what looks like tramadol or, hydrocodone, other substances. And so they may be in powder form as well, which makes it very easy to mix in or cut in with other substances, as well as sold in tablets. The same thing is kind of ringing true here as it did with the benzodiazepines, the designer ones. With the synthetic opioids, you get the same or very similar effects as an opioid would, a prescribed opioid, fentanyl, etc., an illicit source. It attaches to, or they attach to the same receptors of the brain and actually have the similar activity. So things from constipation to drowsiness to, the potential for euphoria and addiction, all of that and then some. Now you'll note that a lot of times these fentanyl analogs or these synthetic opioids, as I mentioned earlier, could potentially be pressed into tabs that look like other substances. So just in the top right-hand corner, you'll see a picture there of an oxycodone pill. This one is a counterfeit pill. Very possible to have fentanyl, obviously, in that, but it's also possible that you may see some of these synthetic opioids mixed in as well. Now, one more time with these synthetic opioids, if you are interested in testing for them, just know that definitively look for a facility that does test for these substances. We do, but again, you want to look specifically at what the more popular ones are out on the street. we, speaking from our laboratory, we make sure that we change our menu from time to time so that we're testing for what's current on the street today. So we don't want you testing for things that aren't out there anymore. We want you to have the power to test for what's popular today. Now, I've listed here at the very bottom on the left-hand side what we are testing for. You'll see the 2-methyl-AP-237, brorphine, and metanidazine. Now, the metanidazine is under a family of designer opioids called isotinidazines or nidazines. Iso is kind of one of the big ones under it as well. Metanidazine out of that family tends to be a pretty popular one on the street today. So with that said, again, when it comes to testing for these substances, just make sure that if you do choose to test for them, that you test specific analytes for the needs of your patient. It just protects you and it protects the patient as well. So if I may, in the last 2 minutes, I want to make sure that I show some of the specific data that, again, the speakers before me shared as well. And so I'll make that transition here for you, and I'll pull up California specific information. And that particular information hopefully will give us a little window, if you will, into what's happening specifically here. So let me pull that one up. All right. Now I'll pull up the Sacramento County practice summary. So this is something we put together. This one, in fact, was from all of last year. Let me just give you the highlights for Sacramento County itself. Total specimens that were submitted to our laboratory was just under 5,000. And again, for that year period, and you can see here the total number of patients tested. For the most part, those that are testing more than 5 times at a time, those are typically treatment facilities. So it kind of gives you a spread, if you will, of what's being tested. This particular section here is quite interesting because it speaks to unexpected results. So let's start with the positive first. So here we have results in full agreement with reported medications, and that's about 60%. And so that's quite encouraging. That's about as high as I typically see it across the nation, is about 60%. But let's look at about halfway down. Illicit substances detected in Sacramento County last year, we saw about 13%. And that is, again, those urine specimens that were sent to our laboratory. Now, what does that look like? I'll give you just a little bit of an overview. For the most part, that focuses on alcohol metabolites, which shouldn't really surprise us. Another one is about 1% cocaine, about 1% kratom as well. And just as a reminder, kratom is one of those substances that it's a part of the coffee tree family, interestingly enough. And at small doses, or low doses, I should say, it's more stimulatory. But at higher doses or higher concentrations, it's more opioid-like. And it really doesn't have any kind of regulation around it. So about 1% positive for kratom, about 13% positive for marijuana, and about 5% here positive for methamphetamine. And again, that's across the county for last year. The last thing I want to show you is we also look at prescribed substances. And I want to draw your attention here to where my cursor is, about the 4th substance from the top for fentanyl. About 4,000 tests were performed looking for fentanyl. Out of that, 64 of those were positive, and about 66% of those were positive with no prescription. So in that case, it's typically indicating an illicit form of fentanyl or an illicit use of fentanyl. So this particular presentation or this particular summary is chock full of really helpful information that, again, speaks to the county. We can speak to a clinic, or we can speak to the entire nation as a whole as well. So with that, I'm going to open it up to some questions as well. A lot was thrown at you, and I'm happy to answer at least one question in the remaining few seconds that I have.
Do we have any questions for Dr. Olson? Very informative.
Thank you, Janet.
Very much.
And I know it can be tough too to think of questions. So if you do have questions after the fact, if Janet, if you could let me know, I'd be more than happy to answer that later on too.
Okay, we appreciate that.
Sure.
And again, it's just really interesting, to actually see different aspects of this, of the epidemic and, how, and where we gather, information, whether it's law enforcement, medical, laboratories, it's all very, very helpful in
Yeah.
finding a solution. So we do have a question. Are you finding any patients that are taking xylazine on its own or only in combination with other illicit substances?
Oh, that's a great question. So we started testing for xylazine early this month, April 3rd, and we've been following it just to see what the trends are. So in our demographic, so again, in those seeking healthcare, what we're finding, and we test in all 50 states. And so what we're finding is that in 98% of the fentanyl positive, in the xylazine positive UAs, so in 98% of those, we also found fentanyl. So whether or not they're using in conjunction or it just happens to be there in those windows of detection, it's another story, we don't know. But in 98% of those xylazine positives, and we're working on probably across the nation about nearly 50 positives right now. So again, it's a small number as we, kind of grow with that. But it kind of tells you that for the most part, we are not in our laboratory seeing them separated. It tends to be almost like what we saw with methamphetamine for the longest time and to this day as well, where they tend to typically be in the UA together. So yeah, so that's the data I have to report right now. But give 6 months and we're going to have probably even more. So I'd love to share that with you all as time goes on. So,
Thank you.
yeah, you're welcome.
Okay, thanks. Thank you again. And like I said, we'll pass on any other questions if we through our emails and through the chat as well.
Sounds good. Thank you, everyone.
Thank you. And so now I'd like to introduce our final speaker for today, Teresa Bible. And she will be providing information on Coordinated Access 101. And she relocated from Shasta County area where she worked various nonprofits, always serving families in crisis. She possesses so much empathy and constantly finds herself drawn to advocacy work for underserved populations. She relocated to Sacramento 5 years ago to be closer to her daughter. Her professional experience includes a center director with Planned Parenthood, crisis line management. She's a truancy officer and also worked with the Child Abuse Prevention Council as a case manager at AmeriCorps Volunteers. So please welcome Teresa Bible.
Sorry. Thank you so much for asking me to come and speak to your group.
So Teresa, I'm sorry to interrupt, but we can't hear you. So I don't know if it's if you can check your settings.
Can you hear me now?
I can hear you a little bit. It's just your volume is very low.
No,
How about now?
no.
How about now? Better?
A
No.
little bit better. Do you happen to have headphones with maybe a microphone on them by any chance?
I don't.
Oh.
Maybe I should walk out and walk back in.
We can hear you. It's just very quiet. So if you want to get closer to the microphone, maybe.
I don't think that's a good idea. I think that we need to figure this out because it's very hard to hear. Did you, on the left-hand side of your screen where it says mute, the up arrow, did you make sure that you had checked select a microphone is the same as your speaker or is your system? That's not working.
It says microphone and speaker.
Yeah, we can't hear you. Oh no.
You know,
We can always arrange for you to come back another time, but let's go ahead and have log out, log back in. Let's see if that works. And if it doesn't, we can always have you. Oh, that's a great idea. Dr. Law said maybe you should call in on your cell phone.
okay.
So what you can do is you can, on where it says mute, you leave computer audio or you switch to phone audio and then you'll call in. Lauren, throw the phone number to call in the chat, please. Thanks for your patience, everyone. Teresa has great information to share. All right, there's the Zoom. Lauren, you need to also put the passcode info in there too. There you go.
Well, I see it all, but it says choose one. So I'm choosing phone call, but nothing's happening here.
All right, so what we can do is we can have you come on to another meeting. We can always record another time as well and send it out to everybody. But Janet, I'm going to turn it over to you since you're leading this the meeting today.
Oh, thank you, Lindsay. So, Teresa, if you want to keep trying, we still have a few minutes left. Does anyone have any questions on the resources that we have with the coalition, or does anyone want to share any activities or that they have that you may have coming up that you want to share with the group? If you could raise your hand and then you can unmute. Doesn't look like anybody has anything going on. Okay, so I'll just briefly share at Sac State. I work at Sac State that, in January 2023, SB 364 came into law requiring that universities have education and access to Narcan on campuses. And so we're happy to say that, we are, putting Narcan in AEDs across the campus. And we are also having several training sessions with our faculty, staff, and students on Narcan. And, we have been distributing Narcan to those interested in having it in the case of accidental overdose. So we're really excited that, we're really getting a lot of support, from our campus community to offer that service to our students.
Can I try again? Can you hear me now?
Oh, yes.
Okay. I was worried about the slide presentation, so I sent it to Lauren, and who would have thought the speaker wouldn't work? So there you go. Thank you, Zoom. So anyhow, I apologize. My name is Teresa Bible, and I am currently the coordinator for the Coordinated Access System through Sacramento Steps Forward. I kind of wanted to explain how I got involved in this and then how the Coordinated Access System kind of coincides. Before I was the coordinator for the CAS system, I was an outreach navigator for Meadowview Women's Shelter out in South Sac. And it was very difficult to be an outreach worker because I only had the ability to refer women to Meadowview Shelter, even though we have about 12 to 15 shelters in Sacramento. I only had the ability to refer to just that one shelter. And so that's how it was with lots of other agencies. If you take X Street, for instance, X Street only took their referrals from the Department of Community Response, which is DCR. So some of us outreach navigators found it very difficult to get some of our clients into some of the other shelters because we didn't have those partnerships, or you just weren't allowed to refer to that shelter if you didn't know somebody through the back door, so to speak, didn't have somebody's phone number who worked there so that you could get your referral in. And so over time, we were hearing from agencies, law enforcement, hospitals, social workers, that we were just creating barriers for our clients. Also, the other thing is clients were not able to call a shelter or show up at a shelter and say, hey, can I put myself on the list? It was only those specific agencies connected to those shelters could make those referrals. So if you'd like to go ahead and put the presentation slide up. So what Sacramento Steps Forward did was they listened to some of the concerns and some of the barriers that our community was facing. And what we decided to do was create a coordinated access system. And that coordinated access system is a partnership between Sacramento City, the County Continuum of Care, the City of Sacramento, and the County of Sacramento. What they did was pull their resources together to invest $16 million to create a coordinated access system aimed at ensuring people needing services would have them streamlined and they would be able to go through and access that would help them navigate. The investment will ensure that we are able to help more people and provide equitable, expedient, and easier to find by our unhoused clients. If you were to go out to an encampment, many of our unhoused folks did not know how to get into a shelter, so therefore they weren't accessing those shelters. So a lot of people ask us, what is coordinated access? Well, coordinated access, like I said, is a streamlined system that's designed to match people who are experiencing homelessness with housing and service options. Each shelter has a specific qualification or eligibility requirements. Not all shelters take 290s. Not all shelters take clients that are in wheelchairs. So what we did is we met with all of the shelters that are involved in the coordinated access system. We were able to figure out all of their eligibility criteria. And what happens is 211 receives a report each day, 3 times a day, with clients that have done a shelter assessment. And if those clients meet more than one shelter's eligibility criteria, they could qualify for more than one shelter opportunity. So that we felt was being a little bit more equitable to our unhoused population. So some of the core elements of access is we were determined to make access much more easier. We wanted more agencies and outreach navigators and other nonprofits to be able to do what's called a shelter assessment. Once the shelter assessment is done, that puts that client on a list for an available shelter. So the more people doing those assessments, the more people are on a wait list for an open bed that becomes available. Therefore, it's providing a greater service. Also, what we provide is problem solving, prioritization, and referrals. We get our database of clients from HMIS, which is the Homeless Management Information System. Most agencies that work with clients that are unhoused are on HMIS, but we are finding that there are some agencies, perhaps smaller ones, that do work with the unhoused populations, but that are not connected to HMIS, and therefore those clients are not being counted. And so we are really encouraging a lot of those nonprofits that are small to get connected to HMIS, because the information HMIS provides is extremely valuable, but it's also counting that client, and that's important. Some of the key players in our CAS system are access points, and access points are where clients can go and meet with a case manager and get an assessment done, or talk to that case manager about what we call housing problem solving funds. And I'll get to that in just a minute. It is also includes outreach or advocates. It includes all of our shelters. It includes service providers, and also many of the housing programs that accept housing vouchers. And the biggest partner that we have currently is our referral entity, which is 211, and it's operated by Community Link, and it's supported by Sacramento Steps Forward. So what can we accomplish together through coordinated access system? Well, our biggest goal is that we hope to stop homelessness before it even begins. I had mentioned earlier about a program called Housing Problem Solving Funds. What that does is those are funds that can pay up to $5,000 for a client that has received an eviction notice or a 3-day pay or quit. So anything that's in the arrears. It can also pay for somebody who's been homeless and has finally found their first home, but can't come up with the full deposits, first and last months, and any other requirements. Sometimes it could pay for a moving van. Sometimes they could pay for some furniture. So as long as it doesn't exceed the $5,000, we can include those types of budget type things. The other thing that housing problem solving does is it helps pay for reunification. Say we have somebody here that lives in Sacramento and they have family in Arizona who say, if you could just get to Arizona, we could provide a stable home for you. If we can verify that that family will take that client in, then we will go ahead and arrange for transportation for that client to get back to family. And therefore we've, hopefully ended their homeless issue. The other thing that we hoped to provide with CAS is shorten the time that people must wait to be assessed. Again, clients just can't call, couldn't just go to a shelter and say, hey, I want to get into shelter. They would have to connect to a case manager, an outreach worker, and have a shelter assessment done. Once a shelter assessment was done, then that client went on a wait list. Now things are different. Anybody can call and get a shelter assessment through 211. All you have to do is call 211, hit 8 and hit 2, and you'll automatically get into the homeless crisis line. So let's just say we have somebody in law enforcement who goes out to a domestic violence situation. That law enforcement officer could have the client call 211. 211 could do the assessment, and if there's an open bed, that client could go directly to that shelter. Before, a client wasn't able to do that, law enforcement wasn't able to do it, social workers, hospitals. It was such a very closed way to get clients into shelter, and now it's open. what we were hoping to do is optimize our existing shelter and housing programs. Sometimes some of our shelters, because they couldn't do enough outreach, they weren't able to fill their beds at the end of the week. And what a shame to have empty beds when we have so many people who are unhoused. So what we did was we also contracted with Elica, and Elica has hired, once they get up to full potential, they'll have what we call 18 coordinated access navigators. So those navigators will take clients that call into 211, have the assessment for shelter done, but perhaps there's not a bed currently open at shelter. Then 211 asks if that client would like to be connected to a camp navigator. And what that camp navigator does is support that client, gives them bus tickets, gets them to doctor's appointment, gets them connected to Medi-Cal, CalFresh, gets them connected to ID vouchers, birth certificates, whatever they can do to support that client until that client's turn comes up into shelter. Once that client goes into shelter, that CAN navigator then does a warm handoff with shelter staff and then closes that client out. Because the goal is once the client is in shelter, they'll be assigned a full-time case manager. There's also on many of the shelters, there are housing specialists. So that client's on its way to hopefully finding permanent housing. And if you could scroll down, I'm going to try to get through this as fast as possible. Yeah, so let's talk about how CAS has been working. We have been publicly launched. We were hoping to by now, but you know, when you start working with different branches of government, you can run into some snafus. So currently we do have 10 shelters that have onboarded with the CAS. We have several TAY, which is transitional aged youth shelters. We also have adult shelters on board. We are currently working with the county and the city to bring on some family shelters. We are hoping that will happen by the summer. So far, we have been in full swing with these past 10 shelters for the last 2 months. March, this is our most current numbers on how CAS and 211 and how all the referrals are happening. So just in the month of March, 211 handled over 2,073 calls. Out of those, 694 clients said that they were currently homeless or at risk of being homeless. 480 of those 2,000 calls were referrals to other crisis resources. So maybe they had a place to stay or they were in their car, but maybe they were calling to look for food. Those would be other crisis resources. 348 of those 348 callers, 207 households were either exited or diverted from homelessness. And 141 households were enrolled in shelter. So 141 people were put into shelter just in March. If you could go down just a little bit more. So our housing crisis line is 211. And like I said, you specifically have to dial once you call 211, you have to press 8 and 2. And our goal is that clients that are experiencing crisis situation or experiencing homelessness today can call this number. And the whole time, particularly for this, for last month, was 4 minutes. And that's our goal, is that a client, as we know, many of our clients are on cell phones, limited time to keep their phones charged. So we wanted to be able to answer those questions in a very, very timely manner. So of those 2,073 calls, we can see that the highest requests by zip codes were 95811, 95823, 95815, 95817. And as I said, the average wait time was 4 minutes and 8 seconds. And the average call time that it took for the client to do the assessment, get on a shelter wait list, was 11 minutes. So of the households referred to shelter, there were 201. 30% of these households that were assessed and referred to a shelter within the last 90 days. The average length time for a client to get referred to a shelter was 14 days. And the average length of time for a shelter referral to do a shelter intake was 22 hours. And 75% of referrals resulted in a shelter enrollment. So you can scroll down a little bit. Those are pretty high numbers for just 1 month. We do have what we call problem-solving access points. So we have, I believe, 10 dedicated access points where clients can go in and do an application for what we call those housing problem-solving funds. The application is very simple. It requests very minimal documentation, and a client knows within 5 to 7 days if they've been approved. Of those, we had 83 households that were supported in keeping their housing or gaining new housing just in the month of March. The average household that requested money, the average amount that was paid out was $3,200. And so just in March, we were able to give out over $270,000 to clients that were able to stay housed or get into some form of new housing. And I think you can scroll down just a tad bit more. What we did notice was that 55% of the households that did call in and requested help because they were either at risk of becoming homeless or homeless were 55% of those were female identifying. And then you can continue to scroll down. I think we're coming to the end. So currently you can see these are the current shelters that are in the CAS system. Already, we were able to launch North A Street 2 weeks ago, and we were able to launch Salvation Army this past Thursday. And coming up next, we are bringing on these other shelters. These are the problem-solving access points that I talked about. And whew, I know that was a whole lot in a short amount of time, but if anybody has any questions, please feel free to ask.
Okay, thank you, Teresa. So we are over time, but we do have a couple of questions. And one is, are the domestic violence shelters part of this? And do you have data on languages spoken by people in need?
So the domestic violence shelters are not included in CAS, and that's for privacy reasons to protect those clients. However, we do have clients that are in domestic violence situations who aren't able to get into those specific shelters, can come into the regular shelters. We do have spoken languages. 211 has access to the language lines. So if a client comes in and needs a different language, they're capable of connecting them to the language line. Also, our CAN navigators through ELICA speak 19 different languages.
Okay. And so if a person is unhoused and has pets, are there any resources?
Yes, you'll be surprised. The majority of the shelters do allow pets, 1 pet per person. I think currently out of all the shelters we have, there's 2 that do not allow pets.
Does anyone else have any questions for Teresa?
Sorry for the debacle there.
No worries, no worries. Technology, gotta love it. But again, we thank you for the work that you're doing, and it's encouraging to see that that they're kind of making the access, to resources, a lot more, client friendly, user friendly, for those in need. So, continue the good work that you're doing. And, again, we thank you for your time. And so with that being said, I'd like to thank everyone for joining us today. Our next meeting, Lauren, when's our next meeting?
Oh my gosh, I'm sorry.
Yeah, sorry.
We actually don't know whether or not we will be having it due to a fentanyl awareness hall that we're arranging now with the county. And so we're in the middle of making that decision, and we'll be sure to send out a lot of email invites and updates as that develops.
Yes, and so we're hoping to have a fentanyl awareness summit sometime in August, so mid-August. So keep your eye on your email, and we'll keep you informed of, whether we'll have another a session, with the coalition, or we'll be sending out invites to the fentanyl summit. So with that, everybody have a wonderful rest of your afternoon. Thank you for everything that you do for us in the community. And Lindsay, did you have anything else to add? So again, thank you again, and we'll see you soon. Okay.
Thank you.
Okay. Right. Bye-bye.